NUR2223, Assessment 2 by Acacia, Angela, Emily, Katie, Kathleen and Rosemary. The issue our team is addressing is medication administration errors within hospitals. The relevant National Safety and Quality Health Service standards for the issue in the clinical risk video are Standards 1, 2, 4, 5 and 6, where we will be focusing on Standard 4, Medication Safety Standard. The issue will involve all members of the hospital, including pharmacy, doctors, nurses and patients. Our SMART goal is to reduce intrathecal and intravenous medication administration error by 50% in 1 year through in-person medication on-site training 6 monthly.
The issue in the video presentation was medication administration error, where the patient received a medication in the wrong route that could potentially result to death. The group project will focus on the standard medication safety. Medication error accounts for over 250,000 hospitalizations in Australia yearly, and 50% of this harm is preventable in healthcare setting. There are multiple types of error reported under medication administration, and giving a medication in the wrong route is just one of them. In relation to the error in the video, there have been several initiatives done to prevent the occurrence of such event, which are changes in medication preparations, printing medication names using Tolman lettering, and printing warnings and medication packaging. However, these errors still occur. With all the numerous interventions currently in place to improve medication safety, the team agreed that education and training would be a good intervention to decrease incidents of medication errors.
The proposed change to reduce the rate of medication errors within hospitals is to provide education and training on the importance of implementing the 8 rights of medication administration. The education will be implemented 6 monthly on a compulsory basis. This training will involve all nursing staff from a facility and will break down each of the 8 rights of medication administration to inform staff on what each right looks like within their practice. Medication errors are often attributed to the administrator not providing their full attention to the task, where encouragement of focused attention during preparation and administration of drugs may be effective. The education of nurses on the importance of abiding by the 8 rights of medication administration will allow for errors of omission and commission to be reduced by ensuring that they know the correct protocol and procedures for safe medication delivery. Whilst there are many factors that contribute to error, the administrator ultimately is the last step in checking that no errors will occur. Lack of medication knowledge and experience both contribute to medication errors. Therefore, increasing the awareness, skills and attitudes of health professionals towards safe medication practices could significantly improve safety. Education that encourages nurses and doctors to check the reason, dose and route for medication delivery by cross-checking handbooks and databases can help to save many medication errors from occurring. By explaining the potentially fatal outcomes to the nursing staff, it may motivate them to take extra caution when administering medication, where they understand that their actions could cause severe harm to the patients that they care for. The reduction of medication errors can be observed through a downward trend of reported medication error, where every error, regardless of severity, should always be reported.
Several studies have shown that insufficient knowledge and lack of therapeutic training in safely prescribing, dispensing and administering medication is an acknowledged contributing factor to increased medication errors. We are basing our intervention and proposed change based on the governance of the 8 rights of medication administration, as well as the National Safety and Quality Health Service, where medication safety is listed as Standard 4 and provides a detailed guidance for the safe use of medication in healthcare. This proposed change will include education and training for all personnel and will involve specifically nurses and all other healthcare providers that can administer and dispense medications, such as doctors and pharmacists. It would also require the use and deployment of education teams such as nurse educators and human resources to monitor staff compliance and completion rates. Resources will include scheduled training rooms twice yearly to accommodate in-person education centres with staff members over a period of a week to allow staff to be able to attend and ensure wards are correctly staffed. Other resources will include posters around wards and medication rooms showing the 8 rights of medication administration to further reinforce educational sessions.
We will organize and test this intervention by using the PDSA cycle, as it has been an effective tool that can be applied to staff education. Intervention plan is to focus and develop the training curriculum on the hospital policy for medication storage, the hierarchy of the personnel, and why it can be a leading cause of medication error, medication routes, particularly particularly intravenous and intrachea, the importance of legible writing, and the 8 rights of medication administration. We will monitor the progress for each personnel participating in the training by using tools such as the pre- and post-quiz feedback and reflection. Provide medication safety training using interactive sessions such as role-play. Provide ongoing support to personnel struggling with the information or who need additional support. To study, we will examine whether the pre- and post-quiz was effective. We will analyze the result of the post-quiz to determine if the training was effective and the level of effectiveness the training had. We will investigate to determine if the staffs are incorporating the learning objectives from the training, and will analyze the data and feedback to determine areas of improvement for the next session. To act, we'll implement changes to the training program based on the feedback and the data collected from the study phase. We'll develop a plan for ongoing education and training. HR will enforce that all personnel have updated their training every 6 months, and non-compliance will lead to disciplinary action. We'll also review the hospital policy and procedures needed based on the final results from the medication education, and will communicate the results of the training programs to relevant stakeholders, including personnel involved and accreditors.
There are different ways in which data can be collected on the effects of certain interventions. Some are more effective and others are more difficult to implement and get accurate results. Qualitative data can be collected, so this could come in the form of one-on-one interviews with the staff about how they feel the intervention is working. There could also be a section in a questionnaire for a long response where they can make comments about their opinions. Qualitative data is mostly subjective and takes into account feelings and opinions, which can be difficult when trying to obtain a success rate for an intervention. However, it allows for context of the effects to be explained, where it can be discussed about why the intervention was successful or unsuccessful, so that a better analysis of success can be collected. Quantitative data can also be collected. Examples are using a questionnaire for the staff, with questions on how often they used the intervention and how many errors they made, using a numerical scale. This allows for numerical data and statistics on the success of the intervention in reducing medication error to be acquired. But it does not allow for an open discussion on ways that the intervention did work and ways it can be improved. In order to allow for the most accurate and reliable results to be obtained, it has been shown in research that a combination of both qualitative and quantitative data is the most effective way to measure the effects of an intervention. The quantitative data can be used to determine the statistics on the success or failure of the intervention, and then the qualitative data can be provided in analysis of the intervention to make improvements.
Once the intervention and strategy has been tested out over a year for a trial on a particular ward, if successful in reducing the intrathecal and intravenous medication administration errors by 50%, it would be implemented and our interventions of medication education would be spread across the rest of the hospital. Further along, given its success, we would hope to be able to spread the intervention into other hospitals and potentially other health services too. Results of the implemented strategy should be reported to all those involved. While the trial is ongoing, monthly statistics will be posted out on the number of intrathecal and intravenous medication errors happening in comparison to the numbers prior to the education that all staff underwent. Unit meetings will be held to discuss the results and make any adjustments to the intervention when necessary. Once the trial is complete, the results will be posted in an article to create awareness of the effectiveness of the strategy within the hospital. To ensure sustainability, consistent implementation of training and education on medications as well as 8 rights will be conducted, and as reinforcement to this training and education, modules will be provided and posters will be put up around the hospital. Training and education will be conducted over an in-person session every 6 months, with refresher modules and quizzes being sent out to staff monthly to complete in their own time. In the future, we hope that medication administration's errors can be continued to be reduced further than 50% by continuing education to all staff and using the use of posters and encouraging best practice.